All this is Dr. Mobeen Sayed, and with me today we have Dr. Priya Jaisinghani once more. We are going to continue with our diabetes mellitus lectures. Today we're going to talk about the diabetes mellitus classification. So before we go there, I'm going to very quickly, for those who are new, Dr. Priya Jaisinghani is a board certified internal medicine physician who completed her training at Rutgers Robert Wood Johnson, New Jersey, and is currently completing her fellowship in endocrinology at New York Presbyterian Weill Cornell, New York. So she received a distinction in service to the community through her work at the Bog Center in medical school and was inducted into the AOA Honor Society in 2019 during her residency. Let's ask her more about herself and then we'll start the discussion. So Priya, thank you very much for being here. Tell us, for the new viewers, a little bit about yourself, and then we'll start the discussion.
Of course. Thank you so much, Dr. Bean, for that introduction. Welcome back, Cool Beans, and welcome to the new viewers as well. I'm Priya Jaisinghani. As Dr. Bean mentioned, I'm currently an endocrinology fellow. It's always a pleasure to be here. I'm extremely interested in, subspecializing really in endocrinology and diabetes and obesity. And I have a passion for medical education. And so I really love teaching. So it's always a pleasure to be here and share some of the knowledge that I'm gaining too. So thank you.
Thank you very much. Thank you for being here. Tell me this, what is nowadays, just one more quick question. Nowadays, what is your routine? What kind of work you are doing? Any research you are doing? What is exciting?
Yeah, so I'm actually involved in a couple of things. Like I said, I'm very interested in diabetes and obesity, and I also have a strong inclination for the thyroid. So I'm currently involved in two research projects. One is actually on diabetes, and it's a novel therapy actually to try to treat diabetes through an endoscopic procedure, so through endoscopy. So it's a very novel thing. And the other thing I'm doing some research on is actually thyroid hormone resistance. So that's something else that I'm also looking into.
These are beautiful areas. I am waiting for some time when we'll have true artificial pancreas that can be just in our body, work like our pancreas, and we are free of the need for external intervention. So with this, let's start a discussion. So I'm going to share your slide. Please guide me whenever you want it to be changed, and I will do it.
Absolutely. So Cool Beans, I hope everyone had a safe and friendly Halloween yesterday. You got to snack on some of those sugary goodies, and hence it's very apt timing to have this lecture, right? So here we are. So I'll give you a quick overview just to recap some of the things that we have talked about, in our first three lectures that we had. So in our first lecture, we discussed how diabetes is referred to really a group of common metabolic disorders, right, that share the phenotype of high blood sugars or hyperglycemia. And in subsequent lectures, then we discussed the importance of glucose regulation and the role of the pancreas as well, right? So, for instance, yesterday when you guys were having, some candy maybe, after eating some of the candy, the glucose levels tend to rise in the blood. And then the beta cells in the pancreas sense the increase in the blood sugar, and then they start to release a hormone called insulin, right? And then insulin sends a signal into the body cells and asks it to remove the glucose from the blood by transporting it inside the cells, where it can be used either as fuel or it can be stored. So that was kind of a summary of where we've been and how the lectures have kind of progressed. So in one way, we can really think of diabetes as a impairment in carb metabolism, which also affects the fat and protein metabolism, either through, as we discussed, a lack of insulin secretion or decreased sensitivity of the tissues to insulin, which is leading to hyperglycemia or high sugar levels. So in the first lecture, if you remember, I had mentioned two different types of diabetes. But today we're going to talk about basically an overview and a classification of all the different causes of diabetes. And we'll go to see that there are several different types. And it's really due to a complex interaction that we'll see between genetics and environmental factors. So we can go into the first slide. Great. So basically, first, I'll start off with some historical background, okay? So I want to give you an idea of why there's such an important distinction when it comes to the nomenclature, really, also of type 1 and type 2 diabetes. So diabetes was recognized actually several centuries ago by Hemsworth, who first proposed that, diabetes could be differentiated into two different types, insulin sensitive and insulin insensitive. And this was back in, 1936. And, based on some studies that some individuals like Lawrence, Burson, Yellow, Bornstein had done, they were able to see that, insulin was first detected in the blood. And during that time, they saw that patients with diabetes oftentimes, according to, whether they were able to detect insulin in the blood, were usually stratified by age of onset. So either, juvenile onset or maturity onset, subtypes of diabetes. So some of you may remember when diabetes was thought of in the terms of juvenile onset diabetes, which was thought to be insulin sensitive, and then maturity onset diabetes, right, which was thought to be insulin insensitive. But as time progressed, we learned a lot more about diabetes. And, the WHO Expert Committee on Diabetes made some changes separating diabetes into a different category, which was actually based on insulin dependency. So insulin dependent, which was type 1 diabetes, and then non-insulin dependent, which was type 2 diabetes. And this is now the preferred classification system, right? And it doesn't necessarily take age into correlation with the insulin dependency as it was thought before. So in addition to that, they actually added a third category, which was for other specific causes of diabetes. So whether that included, we'll see further in the lecture as well, genetic defects, which affected the beta cell function or insulin action, diseases of the exocrine pancreas, endocrinopathies, different drugs or medications. And there's also a fourth category for gestational diabetes. So we'll start with talking a little bit about type 1 diabetes. So we can see here, type 1 diabetes is listed, and it's basically defined by beta cell destruction, usually leading to absolute insulin deficiency. And type 1 diabetes is also called insulin dependent diabetes. So why is it named insulin dependent diabetes? Well, type 1 diabetes is usually, again, a state of hyperglycemia because there's a lack of insulin secretion from the beta cells in the islets of Langerhans in the pancreas, which we had gone through in previous lectures, right? So that means that these patients need exogenous insulin to sustain life. So we can go to the next slide. So, type 2
I have
diabetes.
a question though.
Yes.
Apologies for this. Question is it true that all diabetes eventually become insulin dependent, or they have to become insulin dependent? Or can type 2 stay for a reasonable amount of life, let's say 70, 80, 90? Can it stay non-insulin dependent?
That is a great question. So we're going to see later on, there is a huge spectrum of diabetes. And yes, absolutely, type 2 diabetes can progress to a type 1 phenomenon. But, the degree of the underlying metabolic process, maybe specific environmental factors like your diet and exercise, can either cause that severity to either be the same, maintain, or regress, become better, or you can progress to worsening severity, right? And when that happens, sometimes the beta cells become exhausted. And maybe that type 2 phenomenon can transition to a type 1 phenomenon where you're not having any insulin production anymore. And we'll definitely see that later on in the lecture, and I'll go into a lot of specifics about that. But that's a great question. So it really depends on how well, you're maintaining the care for your diabetes when you have type 2, either to maintain that or improve it, right? And then if it tends to worsen, certainly it can transition.
Got it. Thank you very much.
Of course. So as I was saying, type 1 diabetes, the pathophysiology and the management might seem pretty straightforward, but there's a lot that we actually don't know, right? And as I mentioned, type 1 diabetes is when you have an absolute deficiency of insulin, right? And it's often defined as immune-mediated diabetes. So contrary to, popular belief, type 1 diabetes actually it represents even 5 to 10% of diabetes in adults. Okay, so most people, when they think about type 1 diabetes, they think about children, but it's actually about 5 to 10% of diabetes in adults as well. So when I'm saying type 1 diabetes is immune mediated, what do I actually mean? I mean that there's a destruction of the insulin producing cells of the pancreas, right? Which are the beta cells of the islets of Langerhans. So here I have an image showing basically 4 main autoantibodies that are associated with type 1 diabetes. Okay, so there's islet cell antibodies, there's glutamic acid decarboxylase autoantibodies, there's islet antigen 2 autoantibodies, and there's insulin autoantibodies. So just to go through some of these, so you have, for example, autoantibodies against insulin. And this is, pretty predictive for type 1 diabetes, and it seems to be higher amongst younger children. And that may be due to the higher rate of beta cell destruction that they have. Then you have, glutamic acid decarboxylase autoantibodies, right? And we commonly see that labeled as GAD65. So GAD is actually an enzyme that helps the body produce a specific neurotransmitter called gamma aminobutyric acid, GABA. So GAD is actually present in the pancreas and in the nervous system. So GAD can trigger the immune system to start producing autoantibodies to healthy cells, right? And that's what we can also detect when we come to testing for type 1 diabetes. And it's usually known to be more sensitive than the autoantibodies that we see against the islet cells. And they often remain, detectable for many, many years, even after there's been a lot of loss of beta cell function. And then, there's other insulinoma-associated proteins that have autoantibodies, like we see here, the IA2, right? So this is detected in maybe about 60 to 70% of patients with new onset diabetes. And it can actually be preceded by the insulin autoantibodies or the GAD65. But this one, as compared to GAD65, the frequency actually decreases with increasing age of onset. And then there's one more over here, which is very interesting, which is a zinc transporter. So ZNT8. So we'll see, that zinc actually is a signaling molecule, and it has multiple roles. So it can act, as an extracellular signal recognition. It can act as a second messenger. It can act as a activator with protein kinase. It can participate in phosphorylation in a lot of these pathways that we see. And it can also serve as a regulator with transcription. So, for this specific transporter, now it's been recognized through some studies that when you have positivity of autoantibodies against the zinc transporter, it might actually be related to early onset of diabetes and increased risk of complications, like we'll see in later lectures, like diabetic ketoacidosis, DKA. So those are some of the antibodies that we can test for when it comes to type 1 diabetes. And another interesting thing is, when an individual usually presents with type 1 or autoimmune diabetes, it usually indicates that they have an increased risk of developing other autoimmune disorders, right? So what are some other autoimmune disorders? You can have celiac disease, hypothyroidism, hyperthyroidism, vitiligo, autoimmune hepatitis, pernicious anemia. These are some of the most commonly associated autoimmune disorders that you can have. And there's also a genetic aspect to this, right? So we won't go into too much detail regarding this, but there are some strong associations with certain genes. And those genes would include HLA, DQ and DR. And those are some of the alleles which can either be predisposing or protective. And so, it's generally considered to be polygenic, meaning that there are many genes involved. So that was basically the basis behind us testing for antibodies, right? When it comes to type 1 diabetes. Now, there's also another subset of type 1 diabetes that you can consider, where there are actually theories about destruction of the beta cell by the immune system and even inflammatory involvement. So again, we're keeping this very superficial and basic, but it's quite complicated. So I won't, without going into too much detail, what I can tell you is that there are some theories where there's presence of certain receptors that can predispose to selective loss of beta cells, Okay, so meaning that those beta cells might be targeted in what we call cell-mediated cytotoxic reactions. And another hypothesis shows that maybe inflammatory cells actually infiltrate, and that might be in certain conditions like infections. And we'll also see, throughout this lecture that there are other mechanisms that can lead to a type 1 type of phenomenon when it comes to sheer loss of beta cells, right? Whether that's medications, infections, surgery. So that's a little bit about type 1 diabetes.
Got it. So one question,
Mhm.
why do we say type 1 diabetes is insulin dependent?
Right. So there is a complete loss of the production of insulin. So they are dependent on actually taking insulin. So if you remember, we had talked about the difference between endogenous and exogenous insulin. So endogenous insulin is insulin that we produce. If we do not have any more production of insulin by our beta cells, we have to give ourselves insulin, right? Either through injection or through a pump, whatever means that is. But in order to prevent fatal complications of diabetes, these patients need to take insulin through exogenous routes, and that's why they are dependent on this insulin.
Got it. Thank you very much. So next slide.
Yeah. So here, I have this is really a conceptual model. It's by Eisenbarth, and it was developed back in 1984. And it's something that we still use today. And it's actually to show you really the pathogenesis of type 1 diabetes and how it can truly, be a spectrum as well. So here, we have the beta cell mass listed on the y-axis, and age is listed across the x-axis, and we can see here, there's a interplay, right? So you start off with a certain amount of beta cell mass, meaning how many, the mass of beta cells that you have in the pancreas. And then we can see that there's a sequence of events, right? So I mentioned, there are a lot of genetic factors. So maybe someone might have a predisposition, right, to having diabetes already. Then you could have some sort of event that might happen from their environment, like an environmental trigger, right? Some sort of trigger then causes this autoimmunity that we saw with the different autoantibodies that were detected. And from there, you might have a loss of beta cells. And we'll see, that might start off as, just initially with normal glucose levels. And then over some more time, you might have a dysglycemia, or, where you start to see progression towards hyperglycemia, right? And then you may progress as, you're losing more beta cell mass into overt diabetes or clinical diabetes that we can diagnose. And maybe at that time, you still have some beta cell function where you can still detect a C-peptide, but then you'll go to the point where you're going to have rapid progression and you're going to have complete cell loss, and there's going to be no C-peptide detectable. So you remember in lecture 3, we spoke about insulin, right? And insulin was composed of the A and B chains that were connected by those disulfide linkages. And there was also a C chain, right? And that C chain was the C-peptide that I'm mentioning here. So if you remember, the insulin and the C-peptide were always packaged together in the secretory granules, and then they were secreted. And we were interested in measuring the C-peptide because it used to tell us how much natural insulin a person was still producing, right? And so people with type 1 diabetes, like I said, are unable to produce insulin, which is why they have basically undetectable levels of C-peptide. Okay.
Got it. There is a very interesting question. Renee says, is this common after chemotherapy?
So, there are actually some medications, not specifically chemotherapy, but medications for patients that are on leukemia, who have leukemia, or other medications, a lot of immunotherapies, which may be used in that population, right? In patients who have cancer. And there we can see that they often develop a type 1 type of phenomena.
Got it. Thank you very much.
So we can
Should I
go
move to the next one?
Yes, we can go to the next slide. So now we can talk about type 2 diabetes. Okay, so type 2 diabetes was previously, referred to as non-insulin dependent diabetes mellitus, or adult onset diabetes. So this form of diabetes actually accounts for about 90 to 95% of those with diabetes. And we can go to the next slide. And it's usually a combination, as we can see here, between insulin resistance and beta cell dysfunction. Okay, so when there's decreased sensitivity of target tissues to the effects of insulin, we call that insulin resistance. Okay, and with systemic insulin resistance, insulin signaling within the recipient tissues, so within the glucose recipient tissues, is actually defective. And that's why you have hyperglycemia. Okay, and beta cell dysfunction, what I mean by that is that there's inadequate insulin secretory responses, right? So a combination of those two, when you have beta cell dysfunction and you have insulin resistance, they both induce hyperglycemia, and they're both going to increase the demand for insulin. And eventually it becomes very hard to kind of keep coping with that cycle. So you're going to have persistently elevated glucose concentrations that are going to be above the normal physiological range, and it's going to lead to hyperglycemia. And that can be prolonged, and you can have severe resistance to insulin. And then even though the levels of insulin are increased, it's not enough to maintain that normal glucose regulation. So as a result, if you're not able to maintain that glucose level, you're going to have this altered glucose metabolism that's going to prevent efficient uptake and utilization of the glucose by most of the cells in the body. And initially you might just have a moderate amount of maybe high sugar levels or hyperglycemia after ingestion of carbs, maybe in the early stages of the disease. But then in later stages of type 2 diabetes, as I was mentioning before, the pancreatic beta cells may start to become exhausted. They may start to get more damaged, and they may be unable to produce enough insulin to prevent more severe hyperglycemia. And that could be especially after a person is having maybe a very carb-rich meal, right? So both of these states are going to influence each other, and they're going to synergistically worsen diabetes. So you can imagine that type 2 diabetes can frequently go undiagnosed for many years. Why? Because we just went through the whole process, right? Where it might take time, that it might be very gradual, and at earlier stages, it may not be severe enough for a patient to be or a person to be experiencing, overt symptoms, but also for it to be detectable, right? So that's one reason that it's very gradual. Another thing which is common, how I mentioned in type 1 diabetes that there are genes involved. In type 2 diabetes, there's also a very strong genetic predisposition, okay? And it's very complex, and it's not quite clearly defined. So again, many, many genes are involved, and that's basically where I'll probably leave that. So go to the next slide. Okay, so now this chart is very, very important. So this is a concept which we kind of alluded to already, but I want to take a moment to re-emphasize it now that we've reviewed type 1 and type 2 diabetes. So you can imagine now, based off of what I've told you, that assigning a type of diabetes to a person often depends on the circumstances present when at the time of diagnosis, and then many individuals may not fit into a single class. So labeling the particular type of diabetes is important, but it's more important to understand the pathogenesis, or the reasoning behind the high sugars, and thus the treatment and how to treat it effectively. So what we also see is that, as I mentioned, the degree of hyperglycemia may change over time depending on the extent of the underlying disease process. So like I mentioned, we'll see here in the chart, there are 3 different categories, okay? So in these 3 different categories, we can see a flow between normal glycemia and hyperglycemia with progression to prediabetes and then to diabetes. Okay, and this basically alludes to a very important concept, that even though the disease process may be present, it may not have progressed far enough to cause hyperglycemia, right? So the same disease process may be causing some sort of impairment in glucose tolerance, but it may not fulfill the criteria for the diagnosis of overt diabetes. Okay, so this is where we start to see these differences, and this is why I was mentioning it's really a spectrum of where you fall within these categories. And like I mentioned, in some individuals with diabetes, just having, weight reduction or improving their exercise, they can achieve adequate glycemic control. Obviously, some people need oral medications, right? Some people may even need insulin. So, some individuals will retain enough cell function that's sufficient instead of, becoming dependent on diabetes for survival, like I was saying. And this may happen at a later stage of the disease, though, where there's maybe, little to no insulin secretion. And then that we can detect by a low or undetectable C-peptide, right? So all of this.
I have a question here.
Yep.
So the hyperglycemia, pre-diabetes mellitus.
Yes.
So pre-diabetes mellitus, when we hear doctors saying that, hey, you're pre-diabetic,
Yes.
is that an indication that a person's disease process is kind of about to reach a failure point, and then they would start needing help or take care of their food or change their food or lifestyle? What is pre-diabetes?
Exactly. So pre-diabetes, there's a couple of ways that we diagnose diabetes. And one of the tests that we can use is called a hemoglobin A1C, which is basically a way to see what your sugars have kind of looked like over the past 3 months. So when we look at that, an HbA1c greater than 6.5 usually indicates diabetes as a diagnosis of diabetes. When you have an A1C that's anywhere between 5.7 to 6.4, that's showing us as an indication, hey, you're heading towards overt diabetes. This is the pre-stage. This is when you should really start to try to take care of things before you're diagnosed as a diabetic and have, are then predisposed to all the complications of diabetes. So, if you are alerted to that time where, your healthcare provider or your physician tells you, hey, you're in the pre-diabetes range, you should really take that into consideration and, take all the appropriate steps that they advise you to take, which normally usually include, weight loss, exercise, nutritional changes at that point to kind of have a regress on that spectrum that we were talking about.
Got it. So I'm going to leave you up with the full screen and ask you a couple of questions. Sure. So Alice Nixon says, is COVID-induced diabetes different from typical type 1? And I know that we're doing classification, so I'm not expecting you to go deeper in these things, but if there is a quick answer, it may be useful.
Sure. So, during one of the last lectures, I actually mentioned they, just subjectively, even many people in endocrinology or even many primary care doctors, ICU doctors, noticed that during COVID, we were having many patients who were developing diabetes. And we felt that there must be some role that this infection is playing. And what they've found in some recent research is that it actually changes, there's some transdifferentiation of beta cells. And there may even be, we'll see in the subsequent slides that infections, some infections can cause a type 1 type of phenomenon, but they can also lead to inflammatory, a lot of inflammatory markers and predispositions, which can kind of alter the beta cell function. So the answer to this is that there's still a lot of research going on, but right now they're looking into how beta cells actually change with COVID. But there has been, it has been shown to, cause a lot of complications in people and predispose them to diabetes.
Got it. Thank you. One more question. Stay
Sure.
there on the big screen. The next question is, Matthew Rahman says, is glycemic variability, even if it is low, as dangerous as hyperglycemia itself? And then he has one more question. And I want to remind the viewers, today's topic is classification of diabetes. I'm going to try to keep the structure as close to that as possible. We'll continue to talk about diabetes and go in deeper areas later on as well. So his second question is, we often check FBS, knowing that diabetes is a chronic disease. Shouldn't we check C-peptides?
Okay, great question, Mr. Rahman. So in terms of glycemic variability, So if you ask most people, they will tell you that we are often more afraid of the lows than the highs. And that's for many reasons. When people have low blood sugars, there can be many things that can happen, including them completely passing out, having a cardiac arrest, meaning their heart stopping. It can be fatal, really. So we often in endocrinology are very cautious when it comes to low sugars. That's not to say that, high sugars don't have implications, right? Clearly, that's the basis for this disease where you have high blood sugars. It's very important to control it, but lows are often seen to be worse than highs. So that's why we try to maintain a good balance between a target blood glucose range. And you'll see that, even when you're programming an insulin pump, often physicians can put in a target blood glucose range to kind of avoid sugars being too low, but also avoid them being too high. So that's the quick answer to that question. The second part of your question is actually quite interesting. But, there's a very, so as I mentioned, I guess another quick answer to this question about diabetes being a chronic disease and why don't we check C-peptides? Well, the other thing is common things being common, right? And also looking at the clinical scenario with which patients present. So oftentimes when we have a patient presenting with type 1 diabetes, they can be coming in DKA, which is a emergency that we'll see in subsequent lectures. I'm sure we'll talk about that. So that often is something that signals us if someone's coming in DKA that, hey, maybe they have type 1 diabetes and their C-peptide will be low. But common things being common, most people who are diagnosed, let's say in the outpatient setting in the office, type 2 diabetes is one of the most common types of diabetes, right? And if we look at the whole clinical picture, if they're not coming in with that emergency type of phenomenon, if they have a strong family history, it's probably most likely that they're coming in with type 2 diabetes. So we take into consideration the whole clinical context and the picture. But I don't see, sometimes we have to see what the utility is of tests that we're getting, right? So if type 2 diabetes is so common, then if we got C-peptides, it would be normal. Then we would have to think about how often are we going to check the C-peptides to see when the function starts declining, right? So we have to be very careful with the information that we're obtaining because then we need to know what to do with it. The other thing is, C-peptides can often change depending on, you have to make sure that when you get a C-peptide, it's being looked at in the context of the blood glucose. So it's not very reliable when the sugar is very high or very low. So you also need to look at it in that context. So it's quite complicated, but that's the short answer to those two questions.
Thank you very much. There's a beautiful question that is still out there and it's kind of grabbing my attention.
Sure.
Maybe we can talk about it later on. The question is this: Fidelity Quester says, why can beta cells not be transplanted in humans?
Dr. Bean, our Fidelity Quester has asked the question which you were alluding to during our last discussion. I'm not sure. I don't have a good answer for you in terms of why they can't be directly transplanted. Right now we have, when we refer to the artificial pancreas, we're referring to, a system that's not quite as smart as our physiological system when it comes to pumps and that automated, regulation. But I'm not quite certain, what really the roadblocks are when it comes to why we haven't progressed enough to just transplant these beta cells, But that's a very novel and great thought.
At some point, we will create a startup whose job will be to take healthy people and take their own cells donation and keep them somewhere. And when they need their cells back, then we'll culture them and we'll put them back in them. Well, so let's continue.
Yes, of course. So, no, I always appreciate these questions. I feel like the cool beans are just so smart and intellectual with their questions. So I always feel like we have fantastic questions. So it's always appreciated. But getting back to the lecture, so now we're going to be going through basically an overview of the other types of diabetes, okay? So it'll be an overview with the motive of giving you a broad understanding that there are many, many types of diabetes. And then in future lectures, we'll look into some of the important ones in more detail, okay? So here we're going to start with some of the genetic defects that we can see in beta cell function. Okay, so as I mentioned, there are several different forms of diabetes. So now we're going to be talking about some monogenetic defects that we can see in beta cell function. And one such form is called maturity-onset diabetes of the young, or for short, MODY. Okay, so we can see that there are these forms of diabetes are actually characterized by high blood sugars at an earlier age, so typically before the age of 25, and it represents about 2 to 5% of overall diabetes cases, but it's the most frequent form of monogenic diabetes. So remember I said in type 1 and type 2 diabetes there are many genes involved, so those are called polygenic. This is monogenic, okay? And so here in this diagram, we can see that there are 6 different types of MODY, okay? So there are abnormalities of 6 genetic loci on different chromosomes that have been identified so far. And these genes control many different things in the pancreatic beta cell. So development, function, regulation, and then mutations in these genes can cause impairment in the glucose sensing, in the insulin secretion, but they generally do not have an effect on the insulin action, okay? And many of these, genetic defects that we see here are related to transcription factors. And the inheritance pattern is generally autosomal dominant. So I'll basically focus on, I just want to highlight, here, MODY2 and MODY3. So mutations in the factor, 1 alpha gene, hepatocyte core, HNF, 1 alpha, and then there's the glucokinase. So that's MODY3 and MODY2 respectively. Those are the most frequently appearing. So, it appears in about 52 to 65% for MODY3 and 15 to 31% for MODY2 of the diabetes cases respectively. So let's take a closer look at some of these MODY types, okay? So we can go to the next slide. So do you remember in lecture 3, we spoke about glucokinase? So just quick recap. So, glucose metabolism is initiated by the phosphorylation of glucose, okay? So, and that reaction is catalyzed by the enzyme glucokinase. Remember we mentioned it was also called hexokinase 4. So glucose is phosphorylated to form glucose 6-phosphate, and glucokinase is going to serve as the glucose sensor. By recognizing glucose, it's going to initiate glucose-induced insulin secretion. So in MODY2, there are more than a dozen glucokinase gene mutations on chromosome 7 that have been described, leading to defects in the expression of this enzyme. So if there are defects in the enzyme, which incorporates the phosphate to the glucose, resulting in glucose 6-phosphate, which is the glucose sensor, now we have a problem with the sensor, right? So now there's gonna be a need for an increase of the threshold for the onset of insulin secretion stimulated by glucose. So sometimes, depending on the mutation that happens, it might even be that the enzyme that's being expressed is just unstable, which leads back to a deficit in insulin secretion, okay? And we'll talk more about the clinical implications and treatment probably in a different lecture, okay? But I just wanted to give you an overview of that. So MODY2, relating to the glucokinase, but we can also see here, HNF4 alpha, HNF1 alpha, HNF1B, NeuroD1. These all are defects in different types of MODY, okay? So those are also listed there. But I just wanted to emphasize, the pathway with glucokinase, since we had referred to it in prior lectures, and since it's one of the most frequent, okay? So now we can also talk about another genetic defect. So the disease is called maternally inherited diabetes and deafness, or MIDD, okay? So we saw that there were previously, when I was alluding to this, we were talking about mutations in genes for transcription factors, enzymes in the beta cell, right? This is a point mutation which happens in the mitochondrial DNA. Okay, so if we see in the diagram, the mitochondria is right there where Dr. Bean is pointing. And as the name mentions, this disease has been associated with diabetes and with deafness, okay? So the most common mutation that we see here, they've actually identified even the position, okay? So it's not very important, but just a small detail, it's position 3243, and it's in a tRNA, which is encoding leucine actually, and it's due to a point mutation, which means that it's an A to G transition where adenine is actually replaced by guanine in the DNA. And when that point mutation happens, it actually changes the tRNA molecule structure, and that tRNA molecule, the job is usually to help assemble these protein building blocks to kind of build a functional protein. So when you have a mutation like that, which might affect the structure, you're going to affect the protein production in the mitochondria, right? It's going to be slowed, it's going to be impaired. So a lot of research has shown that, this disruption in the mitochondria is going to lessen the ability of the mitochondria to really function and help to trigger that insulin release, okay? So that's another type of point mutation that we can have. So now we've looked at, some of the mutations in the pancreatic beta cell function, development, regulation, some mutations in these genes that are causing, impairment in glucose sensing and in insulin secretion. So what if we rendered the insulin hormone itself to be faulty? So wouldn't that also lead to hyperglycemia? Yes, right? So let's look at the mutations that actually affect insulin directly. So we can go to the next slide. So you're going to see there are a lot of tie-ins to previous lectures that we've had, okay? So if you haven't seen them, definitely go check them out, and I'll give you a small recap here as well. So if you remember in lecture 3, we also covered the production of insulin, okay? So we have here pre-proinsulin, we have the N-terminal signal peptide, the beta chain, the alpha chain, exactly, and then we have the C peptide. Perfect, in green. So pre-proinsulin is usually cleaved to form proinsulin, okay? So that would be the chains A, B, and C. And most of the proinsulin is then further cleaved to form insulin, which is composed of the chains A and B. And then that's connected by these disulfide linkages, okay? And then you also have the C peptide chain there, which is the connecting peptide, all right? So the insulin and the C peptide, like I mentioned, are then packaged and they're put into these secretory granules and they're secreted, all right? So now there have been genetic abnormalities that have been identified that actually result in the inability to convert the proinsulin to insulin. So now imagine if you didn't have the active form of insulin. This is going to lead to another form of diabetes. And these traits can also be inherited in different patterns, particularly in autosomal dominant patterns. So that's another form of diabetes. There are also other insulin gene mutations, which can lead to other forms of glucose intolerance and diabetes. So now we've seen there are defects in the beta cell, right? It impairs insulin secretion. There are defects in the production of insulin itself. So now what if the insulin hormone was made correctly, but it was unable to perform its action? Okay, so we can go to the next slide.
So a quick question, Kelly says, and I'm going to put you here, can these mutations be picked up through genetic testing like 23andMe prior to development of diabetes in order to assess risk and make lifestyle changes to avoid? That's a nice question, huh?
That's an excellent question. I have heard of 23andMe, but I'm not sure if they can actually detect these particular genetic mutations which would predispose you to these very rare forms of diabetes. I'm sure they might be able to give you some inclination that you have other markers, maybe the more common markers, right, that we talk about when it comes to type 1 and type 2 diabetes, but I'm not sure if they would be able to give you the predisposition for these very specific point mutations. I don't know the details about 23andMe to know if they would actually do that, but very good thought and very good question. But I think they would probably at least offer you the more common ones.
Got it. Thank you very much.
All right. So another tie-in here, Cool Beans. I hope you remember lecture 3 very well because we have a lot of recaps from lecture 3 today. So I hope you remember this diagram from lecture 3. This is the insulin ringing the doorbell, as Dr. Bean says, on the door of its target cells, right, to initiate its effect. So for insulin to initiate its effect on target cells, insulin is going to first bind, right? And it's going to sit on this membrane receptor protein, and insulin is going to bind to the alpha subunits of its receptor. And then there's going to be an autophosphorylation of the beta subunit. And that beta subunit is then going to lead to this tyrosine kinase activity, okay? And the receptor tyrosine kinase activity is going to cause this cascade, right, of different cellular mechanisms. It's going to cause, cellular phosphorylation cascades, which are either going to increase or decrease activity of many enzymes, which we've gone through, including insulin receptor substrates, right, that are going to mediate effects on glucose, fat, protein metabolism. So this is an enzyme-linked receptor, right? So this tyrosine kinase phosphorylation is going to lead to further phosphorylation of other intracellular enzymes, even including insulin receptor substrates, or IRS, as we had mentioned before. So the cell membrane is then going to become more permeable to other things, like we had mentioned, like amino acids, ions, and there's going to be increased transport of all of these different things just due to differences in the change states of phosphorylation, right? So all of these changes can occur within seconds. And then there were some other effects that we had mentioned last time, which were slower, right? So changes in rates of translation of messenger RNA, slower effects with changes in transcription of DNA. So there are many, many effects which we had talked about. So in this way, insulin really changes the cellular enzymatic machinery to kind of achieve its goals, right? Now imagine if there were alterations in the structure and function of the insulin receptor, or if there was some sort of defect in the post-receptor signal transduction pathway, right? So there are many, many unusual causes of diabetes that result from genetically determined abnormalities of insulin action, okay? And these metabolic abnormalities associated with these mutations in the insulin receptor can have a very wide range depending on what they affect, right? So it can either range from, for example, hyperinsulinemia to maybe just a modest hyperglycemia to either very, very severe diabetes. So because these cascades are so diffuse in their nature of affecting different cellular cascades, the nature of the disease process which they can cause is also very wide and vast. Okay, so that's another type of diabetes that we can see.
Can I quickly just ask? So there are a couple of questions. Once again, Dr. Amir Hashmi, your questions are good, but I want to keep the discussion for classification. So I'm going to ask the questions, and Priya, please feel free
Sure.
to. There is, let's do this. Let's have from here. Dr. Amir Hashmi says, DPP-4 inhibitors in congestive heart failure. So this is more of a clinical side. We might actually address that later on. Totally up to you to.
We are definitely going to go through all of the medications in a subsequent lecture, Dr. Amir. So definitely watch out for that.
Excellent. And then Texas Meg says, at one time there was a determination that man-made natural high fructose corn syrup had a negative impact on the Krebs cycle, producing high LDL and diabetes type 2. So I would assume, is this still the case?
That sorry, I'm just reading the question again. At one time, there was a determination that man-made natural high fructose corn syrup had okay. So without talking about the Krebs cycle, but just in general, there are definitely dietary modifications to better control your diabetes by avoiding things like this, right? By avoiding the high corn fructose syrups, for sure, definitely. And then we've also seen changes in lipids, right? Which we briefly went over in lecture 2 with the diabetes phenomenon.
Got it. Thank you very much. So next slide.
Yes. So here we have, okay, so another recap from lecture 3. So when we reviewed the pancreas having endocrine and exocrine functions, right? So cool beans, do you remember the difference between endocrine and exocrine? So the key difference between the two types was that exocrine glands secrete substances into a ductal system to a epithelial surface, right? And endocrine glands secrete products directly into the bloodstream. So we talked about the endocrine hormone insulin and it leading to diabetes. Now, what about the exocrine system, right? So we can go to the next slide. So remember the exocrine system. In the exocrine, pancreas actually assists with digestion of food, right? By releasing this secretion, which is rich in bicarb, which helps to neutralize the acidic environment that's created. And the secretion also includes digestive enzymes. So we can go to the next slide. So what if there was an injury to the exocrine pancreas, right? So any process that diffusely injures the pancreas can also cause diabetes. So this is often referred to diabetes of the exocrine pancreas. It can be called diabetes 3C. It can be called secondary pancreatic diabetes. It has a lot of names, but generally it's acquired processes like pancreatitis, trauma, infections, surgeries like a pancreatectomy, even malignant processes like a cancer, right? So pancreatic carcinomas. And they all have different potential mechanisms, right? Whether that causes, some atrophy. It could be a combination of both, loss of beta cell function. It could be a loss of some of the insulinotropic effects on acinar cells. So, or even, the role of exocrine inflammation. So it's really a combination of mechanisms, but this is a general overview of some of the exocrine pancreatic defects that we can see that'll play a role. And of these, pancreatitis is the most common cause of exocrine pancreatic insufficiency in adults. And we see that the pancreas can become inflamed, right? And it can stay that way. And it can affect the cells where the cells can stop working the way they should. And chronically, it may cause destruction, it can cause fibrosis, and that can affect the endocrine side and the exocrine side, right? And I guess the two other ones that we can talk about would be cystic fibrosis and hemochromatosis, right? So if extensive enough, even both of these conditions will cause damage to the cells and they'll impair the insulin secretion. So we can take a quick look at CF or cystic fibrosis. So we can go to the next slide. So in the normal, just to give you some background before we go into the slide. So in the normal duct epithelia, chloride is usually transported by plasma membrane channels, okay? So in CF, there's a primary defect encoded by the transmembrane conductance regulator, okay? And this is called CFTR. So this gene is actually on chromosome 7, and when you have a defect, it actually results in abnormal function of the chloride channel protein, okay? So CFTR usually regulates even the transport of bicarb ions, right? So the epithelia that have this CFTR allele, if there's a mutation and they're unable to secrete this bicarb, they're actually secreting acidic fluid. And then through this acidity, you might even have, a lot of mucin production, you'll have plugging of the ducts, and this is all going to lead to pancreatic insufficiency, a lot of atrophy of the tissue, a lot of fibrosis in the tissue. Also, you'll see changes in chloride conductance, okay? And that's definitely also been shown to alter beta cell function. So CFTR opening in the beta cell actually allows for chloride efflux, okay? And that will affect your resting potential at that level, which is going to help maintain the optimal insulin levels, right? That's what some studies have actually shown. So studies have shown that, functional CFTR was actually necessary for normal beta cell function. So if you have glucose elicited membrane depolarization, that's going to lead to calcium changes, and that calcium change is also going to lead to Oh, did I lose you guys? Dr. Bean, I'm unable to hear you.
Sorry, I was on mute. So we lost you for a few seconds where you were talking about calcium and insulin?
Yes. So there are differences, when it comes to the ability of the member when it comes to this inhibition of the CFTR in beta cells.
Got it.
So yep. So if we remember from lecture 2, we had talked about GLUT2, right? And this glucose transporter on the pancreatic beta cell. And so here in the diagram, remember we talked about elevated blood glucose levels, which led to increased ATP, and that increased ATP led to decreased potassium influx from the cells, which caused the cell to depolarize and then increase the calcium influx, and then lead to insulin secretion, right? So similarly, the CFTR chloride conductance is altered by ATP, and thus CFTR probably plays a role in glucose-sensitive depolarization, okay? So CFTR dysfunction will cause the chloride to build up, and it isn't able to efflux, and then you're going to have more hyperpolarization, and then the depolarization is going to be impaired, and then that's going to impair the trafficking of the vesicles, and that's going to reduce the insulin release that you're going to have. So that means you're probably going to need more glucose concentrations for that same amount of depolarization, okay? So that is how this is all connected. So now we're going to take a quick look at hemochromatosis. Okay, so we can go to the next slide. So before we get to some specifics of the slide, I'll just give you a brief overview that primary hemochromatosis actually occurs to a defect on an HFE gene, okay? And that's on chromosome 6. And this HFE gene regulates a protein which increases iron absorption. So people with hemochromatosis absorb up to 4 times the amount of iron that a normal, a normal functioning gene would actually regulate. So this leads to high levels of iron, especially in the liver, the pancreas, the skin, the pituitary gland, even in the heart, okay? So we know from prior lectures also that within diabetes, 2 of the organs that I just mentioned, liver and pancreas, are essential, right? When it comes to the different effects that insulin can have. So extra iron deposited in the pancreas can actually undergo a reaction leading to a buildup of something called free radicals, which leads to a lot of cellular damage, okay? And it causes death and tissue fibrosis. It can even cause the beta cells to die, right? Which leads to damage of not only the islet cells, but this damage can also lead to damage of the exocrine pancreas, okay? And then when you have iron buildup in the liver, it can lead to damage. And we know that insulin had important implications in glucose regulation in the liver, as we can see here from prior lecture, okay? So that was the main point of this slide. Now we can go to the next slide, and we'll take a little bit of a deeper dive, okay? So some studies have actually shown, and we're gonna go through this very briefly, not to have this in too much detail, but that iron regulates the function of the pancreatic islet beta cells via multiple pathways, okay? So as we know that, you need very tight control of this insulin secretion and sensitivity, right? So somewhere iron metabolism is essential for this. And one of the pathways that it's involved in is iron's effect on ATP, which we also know is essential for glucose-stimulated insulin secretion. So iron overload in the pancreatic islets actually alters reactive oxygen species and also something called hypoxia-inducible factor 1 alpha, where we see here HIF-1 alpha, right? And also affects ATP synthesis. So it's going to impair the function and the viability of beta cells. So an optimum level of HI1 alpha promotes insulin secretion, but iron-dependent HIF1 alpha hydroxylation, so iron actually affects HI1 F alpha through hydroxylation and also degradation, and that's going to suppress the glucose-stimulated ATP synthesis and insulin secretion.
That's very interesting. So does this mean, as we say over here, excessive or deficient iron or HIF1A will increase or reduce the ATP ADP levels. That means iron fluctuations above or below normal both can affect the insulin outcomes or the beta cells functional dysregulation.
Precisely. It's a very interesting concept because we see here, recurring themes where it's absolutely amazing, that these pathways and the amount of regulation that we have in the body through different things, whether it's neurotransmitters, ions, things like iron, which play such a role in maintaining the tight control of not only like sugar and insulin and metabolism, but even the amount of maintenance that's required with optimal levels of these small factors and how they affect these pathways, right? So can you imagine if too much or too little is a problem? It has to be just right? It's like the three little bears.
Yeah, so it's like so let me ask you this question then, and I'm fascinated by this topic. If you felt that, hey, we should move this part of the discussion to a next lecture, totally fine. Question is, we know many folks, for example, in women, sometimes iron is deficient very commonly, and or there are people with pernicious anemia or those, and there are other reasons for iron deficiency as well. Do they have predisposition towards diabetes or not diabetes? What happens? Is there any correlation there?
Yeah, so it's interesting because, people who, for example, with hemochromatosis, it actually, and women, for example, who are menstruating, they kind of are able to offset that increase in iron load, right? But through natural process of menstruation, for example, whereas other individuals may need to have phlebotomy, right? Or removal of the blood to kind of get rid of that excess iron. But I'm not sure in cases where, people may already be deficient in iron, if that's going to lead to, a quicker phenomenon of them developing diabetes.
Interesting.
So maybe
Interesting topic. I'm going to do some research.
Yeah, exactly. We can do some research on that and definitely bring it up. But there are definitely, other things that we follow, like vitamin D, right? And other markers that we definitely follow as well, where you want to maintain some sort of optimal level. So I'm sure there must be a correlation with this as well, because there are so many studies showing that iron plays such an important role.
Got it. Thank you very much.
Of course. So we can move on to the next slide. All right. So we also spoke about in lecture 3 that there were a lot of potentiators and amplifiers of insulin secretion. So we had mentioned that there are amino acids, there's fatty acids, there's hormones, there's neurotransmitters. All of these can affect insulin. So there are many hormones actually which antagonize insulin action. Okay, so some of those are growth hormone, cortisol, glucagon, epinephrine. So we can see excess amounts of these hormones in some disease states, and I have some of them listed here. So for example, acromegaly has excess growth hormone, okay? And in people who have acromegaly, generally about 50% of people have some sort of disturbance in their glucose regulation. With Cushing's syndrome, you have excess cortisol, right? Again, up to about 50% of patients have some sort of disturbance in their glucose regulation. We have here listed a glucagonoma, which basically refers to excess glucagon. And then you have hyperthyroidism. Interestingly enough, hyperthyroidism can play, can contribute in many ways to developing diabetes, whether that's through a autoimmune mechanism. Remember we talked about in previous slides where one autoimmune condition may predispose you to another autoimmune condition. So if you have, an autoimmune type of hyperthyroidism, you may be predisposed to an autoimmune type of diabetes or vice versa. At the same time, excess thyroid hormone, when you have hyperthyroidism, the half-life of insulin is reduced, and that's most likely secondary to an increased rate of degradation and maybe enhanced release of even some inactive insulin precursor. You can also have other effects like increased hepatic gluconeogenesis, a lot of different things. So the thyroid can actually act in multiple mechanisms when you have excess hormone. And then you also have, conditions like pheochromocytomas, right? And these are catecholamine secreting tumors that usually come from the adrenal medulla. And and they can lead to hyperglycemia. In the pancreas, epinephrine will inhibit insulin secretion, and in the liver, it's actually going to increase transient glycogenolysis, and it's going to sustain gluconeogenesis. So again, in pheochromocytomas, we'll see up to 50% of patients having some sort of disturbance in glucose homeostasis. So we'll see that, whether it's through medical conditions or even through medications later, we'll see how you can have disturbances this way.
Got it. So can I ask you a couple of questions that are really interesting?
Sure.
One question is very much related to the discussion that you were just doing. So Texas Meg says, heavy steroid use, for example, COVID-19 treatment, may result in diabetes, and steroid use generally type 2. Wondering what's ahead of survivors. So
excellent question.
Any reason of steroid use?
Yes. So we see this very, very often. Steroids definitely induce higher blood sugars. Up to what effect that has is different. Some people can have what we call a transient increase in their blood sugar. So meaning, you're on steroids for some amount of time. During that time, you might be having higher sugars than normal, and that can be controlled either through medications if needed. Some people, however, may have some sort of predisposition from before. And that predisposition from before, plus an inciting event, right? Remember the graph that I had shown, which had, you have some sort of predisposition and then you have an inciting event. That inciting event might be a medication, right? And that medication could be a steroid, right? And that, in conjunction with the predisposition you have, might trigger, severity of the underlying process, whether that's autoimmune or metabolic or however it is. But again, we'll see here, it's such a key thing, right? Your genetic predisposition plus the environment, and your environment can include medications and drugs, right? So you're absolutely right when it comes to that question, Texas Mag. We are very careful when people are on steroids. Our goal is to always maintain people on steroids for the least amount of time on an adequate dose that's just enough, but not too much, right? Because we don't want to exacerbate things. So when we talk about steroids, we try to be very careful with its use, where we're balancing between efficiently managing someone's condition and treating them, but not exacerbating other things. So you're absolutely right. We have to be very careful. And steroids are used for many other things, right? Many, many other treatments. So it's something that we really have to watch out for. It's something for which endocrinologists are often consulted in the hospital. We get called a lot for that. I've seen it, definitely while treating patients with COVID. We've gotten called to help manage people's diabetes while they've been getting treated with steroids for COVID. So you're absolutely right. I think out of this pandemic, we've definitely seen a rise in the cases of diabetes, and we're going to have to really, cope and cater with the people that have now developed diabetes as well.
So one more question, nerding out.
Sure.
And I think we are so blessed to have you that you already look like you nerd out on endocrinology. Here is another question, and I am so proud of Cool Beans that they can actually nerd out about this with us.
Absolutely.
Denise, So Denise says, so interesting fact. So we were talking about iron. With MCAS has very low ferritin levels, such as myself. Could it actually be a protective mechanism gone overboard? So the mast cell themselves becoming dysregulated, are they trying to somehow help with the iron levels?
Yeah, so there's, a lot that we don't know. And that's what I was trying to say. The interplay between the immune system, the inflammatory system, and how they interact with the beta cell, right? And down to things such as iron, ferritin, all of these different things where we don't quite understand every single mechanism. And you can imagine why, right? There's so many different pathways with so many different steps that can be altered along the way. And it could be a protective mechanism, right? Not quite sure to be able to give you a direct answer, but it's a very novel thought, because there are a lot of disease processes where one sort of what people might quote as an abnormality might actually be a protective mechanism for some sort of other disease state process, right? So we do see that in other disease states.
Got it. Very quick question, and then we continue with your presentation too. Dr. Amir Hashmi says, how to differentiate between type 1 and type 2 if C-peptide levels are normal?
Good question, Dr. Amir. So I will say again, going back to the spectrum analysis, right? We can see how it can be very difficult to type a patient as type 1 or type 2, especially when you have a normal C-peptide, right? But a lot of that has to do with the clinical picture. So you have to take into consideration the clinical picture and if they've had any inciting events and where they're taking that turn, right? So for example, I've seen, for example, on the endocrinology service where you may have patients who may be on immunologics, right? And we know that they predispose patients to developing a type 1 type of disease state or phenomenon. It may start out that those patients can be treated with minimal measures, but we subsequently keep checking their C-peptide, and then we may see an acute drop, and then we have to treat them as a type 1 diabetic. So a lot of times it depends on the clinical picture of what you're seeing in terms of what is actually happening, right, to the person. Sometimes we have to go beyond the lab values, right? Because in essence, these are numbers, but we have to look at the whole clinical picture, the history, the inciting events, and the progression, right? The changes that are happening. So we have to be very mindful with all of those things. So it's a great question, but sometimes besides just the lab work, we have to rely on history and what is actually happening to the patient.
Got it. Thank you very much.
Of course.
Back to the sorry for the
No,
distractions.
I am actually loving it. I think, this was really a loaded lecture. And I think this will also help people who are watching this lecture understand why it's, so difficult, like Dr. Amir's question, to categorize people with diabetes as what type of diabetes they have. But also, I think many people may just think that there's only type 1 and type 2 diabetes, right? And there are so many different types we're learning today. So I think it's really a good showcase of just how broad diabetes can be and why it's truly a spectrum, right? And like I said, we're learning more and more about it every day. And I'm sure in the coming time, there will be many different advances and we'll learn more about each of these different types.
Absolutely. Thank you very much.
Of course. So I guess we were talking about endocrinopathies. So generally, with these endocrinopathies, again, you may have people who have an underlying predisposition, like I was saying, and that might be exacerbated in these disease states. So I guess that was pretty much all I have to say about endocrinopathies. We can probably move on to the next slide, and we can talk a little bit about genetic syndromes, okay? So there are many genetic syndromes which are accompanied by an increased incidence of diabetes. And some of them are going to include chromosomal abnormalities like Down syndrome, Klinefelter's, Turner's, and I've included a whole list here. I won't go into too much detail regarding each of them, but there's a whole list here. There's also Wolfram syndrome, which I wasn't very familiar with. It's quite rare, but it's an autosomal recessive disorder, and it's characterized by insulin deficient diabetes, and some other manifestations as well that you can have with it, with neural deafness, optic atrophy, hypogonadism. So there's a lot of different syndromes that are associated with diabetes. So that's another way, that should also be on your radar. So now we can go on to the next topic. Okay, so now we're going to getting more into environment. Okay, so we talked a lot about the beta cell, differences in regulation. We talked a lot about insulin itself. We talked about insulin action. We talked about genetic diseases. Now we're going to be talking about kind of how the environment is going to affect diabetes. Okay, so infections, right? So there are a couple of infections which are notable for this: cytomegalovirus, Coxsackie's virus, rubella. So certain viruses have been associated with beta cell destruction, and diabetes can occur in patients with these infections. And a lot of them may even have other immune markers, okay, which are characteristic for type 1 diabetes. And there's many different hypotheses about the mechanisms through which viruses kind of may be capable of maybe initiating even a type 1 type of phenomenon, right? So some of these viruses might promote autoimmunity. Some of them actually go through a phenomenon called molecular mimicry, and we're not going to go into too much detail regarding it, but essentially, there's a T cell, and on the T cell, you may have a receptor, and maybe that receptor, the virus can kind of mimic to match that receptor and kind of activate, some sort of autoreactive T cells and basically enable these cells to recognize the viral antigens, and then it kind of propels this whole cascade. Okay, and so you can have this molecular mimicry. You might have autoimmune responses. It can also change maybe pro-inflammatory states. So there's a lot of different theories about how viruses can kind of contribute to the phenomenon of diabetes. So what else can change in your environment? So we can go to the next slide. We kind of referred to it already. So medications, right? Drugs. So we talked about some of these briefly when it came to endocrinopathies in terms of excess hormone. So, and even through the questions which were asked, so whether we take them or we produce them, if you have excess, many of these can actually inhibit insulin action. Many of these drugs can actually impair insulin secretion. And they may be precipitating more in individuals that already have some sort of underlying insulin resistance. And there are certain toxins also, right? So there's also, like, for example, here listed is Bacor, which is a rat poison, or you can have pentamidine, and these are known to permanently destroy pancreatic cells, okay? And then there's also medications like interferons, for example, which have been reported to develop diabetes, and they're associated with islet cell antibodies, and in certain instances, it could even lead to like severe insulin deficiencies. Okay. So now we've talked about medications, right? Toxins, infections. So how else can we change the environment? So we can go to the next slide. So pregnancy, right? So gestational diabetes, GDM is actually can lead to complications in about 4% of all pregnancies in the U.S. And GDM is defined as any degree of glucose intolerance with onset or first recognition during pregnancy, right? And during pregnancy, the placenta makes lots of hormones. Okay, so some of these hormones, again, they block insulin. So some of the hormones which are produced are estrogen, cortisol, human placental lactogen, and they lead to insulin resistance. And to compensate, the body makes more insulin. But if you have GDM, the body can't keep up, right? So without enough insulin, the glucose in your blood rises higher than normal. And generally, screening is recommended based on risk factors. So people, who are more predisposed, who have more risk, may have an initial screening, but they can be retested usually between 24 to 28 weeks of gestation. And high risk for GDM is usually marked by obesity or maybe a personal history, right? Maybe in prior pregnancies, if you had gestational diabetes, strong family history of diabetes, those people usually undergo testing soon, but others can wait till about 24 to 28 weeks, based on average risk. And treatment can vary, again, depending on the spectrum. It can be maybe just diet modification, or it can even be insulin, right? They may need insulin. So in terms of the diagnosis, we have here a glucose tolerance test, okay? And basically, these are just the cutoffs of the numbers. So you'll have some sort of glucose load of 100 grams. And then, we measure the fasting before you have that glucose load. And then we check the sugar 1 hour after, 2 hours after, 3 hours after. And these are the glucose cutoffs for basically diagnosis at every single stage. Okay. And there's also different ways to approach the diagnosis of GDM. There's a one-step approach and there's a two-step approach, which we won't go into details, but there's different criteria for diagnosing gestational diabetes. I'm sure we can go into more detail regarding that in subsequent lectures. But another
Sorry,
yeah,
please complete your thought and I'll have a couple of questions.
sure. So another interesting thing is that, like I said, during pregnancy, the placenta makes a lot of hormones, right? So once you deliver, because the placenta is out of the body when the baby is delivered, the gestational diabetes usually goes away when the baby is born. But with gestational diabetes, you're also predisposed to developing diabetes later. So generally, post-pregnancy, a couple of weeks after, maybe about 4 to 8 weeks after, most people get followed up at around 6 weeks. They're also tested at that time to see if they've developed diabetes. But they do have a higher predisposition to developing diabetes than someone who had normal blood sugars during their pregnancy. And it's quite high. It's almost 10-fold higher, the risk of developing type 2 diabetes.
Got it. Thank you. I'm going to show you a couple of comments. I think you're going to smile. So here is a comment. So I'm going to ask, Doug, I'm going to ask you a question too, but here is a fun comment. Louis Grande says, just took a break from studying endocrine system today and look what I stumbled on into.
You can't just get a break. I mean, it just beckons. I mean, yesterday was Halloween. We had sweet stuff. I'm sweet. Dr. Mobeen is sweet. We have to talk about diabetes. It's everywhere.
Medicine chases you everywhere.
I know. And the endocrine system is something that is so tied into every other body system. It's just not escapable.
Here's another cute comment. So time warp. Hi, Beans and Doctors. Just woke up here in Australia. Wonderful to get the live on such an important subject. Thanks, Doctor. So worldwide, we have folks joining us as well. They're waking up to us.
Wonderful. Well, hello there. Thank you for joining in from Australia.
And one question as well. So Doug Gross says, thyroxine destroys pancreatic cells, ? Does it?
So thyroxine, So thyroxine, we're basically talking more so about hyperthyroidism versus thyroxine when we're talking about developing diabetes. So that's what I was referring to before rather than thyroxine.
Got it. Thank you very much. I'm going to see if there is any other question before we go back to the... So Dr. Amir Hashmi, your questions are great, but they are more clinical. We would reach those points as well in the future discussions. I just don't want to keep stretching this one beyond the classification and related matters. So if I go back to this one,
Sure.
Should I go to the next?
Yeah, I mean, so basically what I was saying was that there's two different approaches to diagnosing gestational diabetes. And the last thing I'll mention, which is important, is you really want to manage your gestational diabetes, and that's for a couple of different reasons, because it can also affect the baby, right? So babies actually can grow large if the diabetes is not well controlled, and that actually makes it very hard for a vaginal delivery. Not only for mom, but for the baby. They have increased risk of shoulder dystocia or injury to the shoulder where the baby can get stuck. The delivery with a larger baby can obviously increase risk of injury for mom, right? With severe lacerations or cuts. And then, you could even have risk of injury with the baby with bones or nerve injury. And generally, during pregnancy, gestational diabetes can increase your risk of high blood pressure, and also, because of the reasons I said, even having a C-section, right, rather than a vaginal delivery. So these are some of the few reasons why it's also important to control your gestational diabetes. And like I said, it can be through either just dietary modification, or it'll be through insulin, because a lot of, as we know, during pregnancy, it's very important to watch what medications you're on, and insulin is usually the medication of choice when we're treating gestational diabetes. If someone needs to be on medication where they're not able to be controlled just with dietary modification.
Got it. Thank you very much.
That's okay. So that was pretty much it. So I think, like I said, in conclusion, I'll basically state that there is so much more to diabetes than just type 1 and type 2, right? And I hope, Cool Beans, that you saw that today when it came to basically an overview or a classification of diabetes. And we went through a very interesting spectrum, right? So with type 1, we saw that it can be autoimmune. There can be some roles of the immune system, the inflammatory system. We saw that other things can lead to a type 1 type of phenomenon. And there's also type 2 diabetes. Both type 1 and type 2 have genetic predispositions. Your environment also plays a huge role, whether it comes to your diet, but also other things like medications that you may have, exposure to different toxins, even other medical conditions that you may have, right? Whether that's autoimmune disorders, which can predispose you to other autoimmune disorders, or genetic mutations in different disease states, or affecting the whole pathway, whether it comes to injury to the pancreas or injury to beta cells, regulation, function, whether it comes to actual genetic modifications which affect the insulin itself, whether it comes to actions that are changed, mechanisms of action of insulin itself, even if it's being produced correctly. We saw that insulin may not be produced correctly. So we saw a whole spectrum, and we saw a very complex interaction between genetics and the environment. And I think the key thing that I want people to take away is that diabetes is truly a spectrum, and that it is a very wide spectrum with an interplay with genetics and environment, with the basis of high blood sugars being the common thing between all of the basis of the disease state. So I know we went over a lot today. I'm sure Dr. Bean and I will go through certain aspects of the lecture again in more detail in further lectures. And thank you so much for all the lovely comments. It's really encouraging to see when we have an audience worldwide. We have the Cool Beans joining in at all different times of the hour from all over the world, and you guys are amazing. Thank you for all the love and support. Always grateful to be here, Dr. Bean. Oh, wow. All the way from Afghanistan, we have Madi or Rahman. Thank you so much. Yes, I can't wait for further lectures as well. Really, really loving the experience that I'm having here. So thank you, Dr. Bean, always. And thank you, Cool Beans, for keeping it so engaging. And thank you for the amazing questions. Sometimes we don't know everything, whether that's through, the scientific studies, our progression, or just our knowledge ourselves. And I try to keep it very honest. When I don't know, I let you know I don't know. And when I do know, I try to answer the question to the best of my ability. But keep the questions coming. I absolutely love it. I think Dr. Bean and I learn a lot through them as well. And we love the engagement. So please stay tuned.
Thank you very much. Thank you very much, Priya. It is actually so great to hear from you the aspects that we as laymen, laywomen should all know. And then when you nerd out and you actually start going in depth, it shows that here is a fellow of endocrinology who is going to be a great doctor in the future as well. I love to see this. And I am a mechanisms guy. So when you go deeper into these areas, it's very exciting. So I think these are gold mines for everyone, medical students, nursing students, common folks who want to understand this. And we are building a platform of knowledge for diabetes, from where people can go and figure out in all directions, lifestyle changes, food changes, keto, not keto, but an understanding of basic mechanisms is very important. So thank you very much.
Of course. Thank you, Dr. Bean. Thank you, Cool Beans. Always grateful to be here. Join us for the next lectures. Can't wait to see you.
Thank you very much. And Cool Beans, this is the lecture for today. So we will not meet tonight. We will meet again tomorrow at 6 p.m. Pacific time. Thank you very much. Bye-bye for now.